The goal of this video is to demystify dizziness. If you ask most emergency clinicians what their 5 least favorite chief complaints are, dizziness will invariably be included. It is one of the most frustrating chief complaints in the ED. Dizziness is scary because there's a chance of missing something dangerous, in spite of the fact that most of the time dizziness is benign in its origin. A consistent approach to the dizzy patient can make this chief complaint more tolerable to you as the clinician and improve safety and satisfaction for our patients. The first step in caring for the dizzy patient is to stop asking what it feels like. You may have discovered through your own experience that you can ask the same patient 2 different times if they feel lightheaded or like the room is spinning, and they will tell you 2 different things. Sometimes they tell you 2 things in the same sentence. Is the room spinning? Yes. So you don't feel lightheaded? Well, I do. It's a question that adds to your frustration and adds to their frustration and provides little to no useful information. Instead, there are some historical questions that make things more useful for us. An appropriately collected history can help us break this into bite-sized chunks to make a safe disposition. The first thing to unpack is if the symptoms are continuous or episodic. Continuous symptoms, accompanied by nausea, vomiting, nystagmus, head motion intolerance, and gait unsteadiness, lead us to acute vestibular syndrome. By contrast, episodic vestibular syndrome has 2 subcategories requiring discussion. Spontaneous episodic syndrome is not triggered by anything and usually lasts minutes to hours with resolution between. As the name implies, triggered episodic dizziness is caused by movement such as moving the head or standing. Acute vestibular syndrome is where most of the bad stuff is. These patients do not have episodes of improvement. They are dizzy and often worse with head movement. They are not triggered, they are exacerbated. These patients need a targeted posterior circulation examination. Walk them. Can they walk unassisted? What's their gait? Is there any truncal ataxia? Luckily, the most common causes are going to be labyrinthitis and vestibular neuritis, both of which impact the 8th cranial nerve, are usually viral and mostly self-limited. After your history points you towards acute vestibular syndrome, physical examination will be used to decide if the patient has a benign or more malignant process. Start with nystagmus. Look for horizontal and unidirectional nystagmus. If there's no nystagmus, it's not likely to be a peripheral cause. Also, vertical or direction-changing nystagmus suggests a central cause. If you suspect a central cause at this point, you don't need to carry on with the HINTS exam. Test one eye at a time, cover and uncover the eye. If you see vertical deviation, it is a positive test and suggests a central cause. Horizontal movement is not considered a positive test. Rapidly move the head 10 to 20 degrees. The reassuring finding here is a catch-up saccade. Basically, we expect the eye to struggle to stay focused and then it catches up. Presence of this is reassuring and absence of this is suggestive of a central cause. Complete a good neuro exam to look for gait, finger-to-nose testing, rapid alternating movements, focal weakness, and any other signs of stroke. Consider risk factors. Risk factors for stroke should increase your index of suspicion. Atrial fibrillation, diabetes, hypertension, hyperlipidemia, and history of stroke should always get your attention. History of similar symptoms with a benign cause lowers your suspicion. The point here is to consider the entire picture. Any evidence of a central cause should be managed with admission. Important indicators of a central cause include positive findings on the HINTS exam, focal weakness, and significant gait disturbance. A good rule of thumb is that if a patient is normally able to walk but now can't, they should probably not be discharged home. Also, ask yourself if there are any other reasons your patient could be dizzy. Dizziness has a broad differential diagnosis, including fluid and electrolyte dyscrasias, anemia, peripheral and central causes, toxicological causes such as carbon monoxide poisoning, and cardiac causes. Although not the subject of this video, make sure to get an EKG to rule out cardiac pathology such as dysrhythmia or other channelopathies. Patients presenting with the chief complaint of dizziness often have a benign cause. However, dangerous causes do exist and should be explored with a thorough history and physical. Focus on timing and exacerbating factors. Rule out cardiac causes and consider the broad differential. Be sure to look at the entire picture. Script your questions and do the same exam the same way every time. Rest assured, a consistent approach to dizziness can make this chief complaint more straightforward and less frustrating for all parties. For Team Health, I'm Dr. Patrick Cody. Thanks for watching.